Hello, I am Dr. Deborah Reed, and I am honored to be here today to talk to you about headache and diagnosis and treatment and special considerations in fibromuscular dysplasia. I'm going to move this just a little bit here. Okay, so I am a associate professor at Case Western University and the director of headache medicine. Today, we're going to talk about a condition many of you I know suffer from, which are headaches. And while there's many kinds of headaches, from TMJ, from sinus disease, from cluster headache, from tension headache, migraine headache, and neck pain, today we're going to focus mostly on migraine. Um, So migraine, the consensus statement that came from the American Headache Society is that it's an inherited disorder and it's characterized by neurologic, sensory, autonomic, vestibular, cognitive, and gastrointestinal symptoms, and maybe even immunologic symptoms as well. Next, we're going to talk about the burden of migraine. So when we interview patients who have migraine or chronic migraine, we find that about 50% of them report severe impairments, meaning that they need to bed rest and stop all activities. Also, functional impairment can happen, meaning that you may not be able to do things in the way that you wanted to do them. So maybe you need to slow down, you don't get things done as well, maybe you need to rest in between activities. Definitely we see disruption of family activities, soccer games that are missed, performances that are missed, even weddings. I've had patients who have not wanted to be in a patient's wedding because they couldn't reliably say, yes, I am going to not have a migraine that day. The patients with migraines can feel stigmatized, and I've heard so many times from my patients that would say, I just wish so and so could feel like what it's like to have a headache just for an hour. Patients with migraine have comorbidities, and migraine can cause a lot of direct and indirect costs. So if you have migraine, I would like to let you know that you are not alone. So about 38 million people in the United States have migraine, which is about 12% of the population. 25% of households have a migraineur in their home. And disappointingly, only about 48% get a correct diagnosis for migraine. Most of the common misdiagnoses are sinus headache, tension headache, and cervicogenic headache. About 60% of migraineurs use over-the-counters and non-prescription medications for their attacks, some successfully, some not successfully. And about 39% of our patients need to seek bed rest at one time or another. There is a genetic risk if one or both parents have migraine, and you can see there it's 70 to 90% if both parents. Over $24 billion are lost to migraine each year, and this is either from people not showing up to work and productivity being lost, or what they call indirect cost, meaning the presenteeism. Patients can show up to work with the migraine, but not perform in the way that they would like to. And headache is the #1 chief complaint in a pediatrician's office. The impact of migraine on patients' family and social lives, and these are two very large epidemiologic studies, meaning they survey a large number of people. You can see there 4,000 people. One in the AMPP, which was a large study of migraine patients, and then the other is a Cameo study, which is specific to chronic migraine patients. And we'll talk about the difference between episodic and chronic migraine. But you can see that many people missed their share of housework, many people missed family activities, and many people missed important events such as a wedding. So the pain of migraine is very severe. Next, we're going to talk about what's the best treatment for migraine and how is migraine diagnosed. So when you show up to your headache provider or primary care provider asking them to help you with your headaches, the thought process that they're going to go through is excluding secondary headaches, meaning headaches from other things first. And especially in a fibromuscular dysplasia population, of course, your provider is going to worry about your blood vessels and consider if that might be adding to the situation. If they are unable to find another cause, they're going to identify the primary headache syndrome, they're going to diagnose it, and they're going to identify things that make it worse as well as things that are comorbidities or things that go along with it. Then assess the disability and attack characteristics, and then treat. So secondary headache, we use a mnemonic called SNOOP criteria, and SNOOP 5 because there's 5 P's. But these are clues that the headache that somebody is suffering from is not your general migraine headache. These might be fever, weight loss, if we know you have cancer or other risk factors. So the fibromuscular dysplasia patient we would consider differently because we know that you can have blood vessel problems. And one of the things that if this headache is dangerous, we look for an abrupt peak, meaning that it happens in a minute. Well, most migraines will develop over 5 minutes. If it's sudden thunderclap, then we have more risk for arterial diseases, and that is a definite emergency room visit. So we always say first or worst headache definitely needs to go to the emergency room. If there's neurologic symptoms or signs, and then some other things that would suggest that it is not a migraine, such as older, which is over 50, which I don't think is all that old, and then change in previous headache, postural headaches, if certain maneuvers, Valsalva, which is bearing down, like having a bowel movement or coughing, if some of those cause the headaches, and then some other things that might go with it, like pulsatile tinnitus or pregnancy. And critical questions for patients in the ED, if you have a headache and new abnormal findings in a neurologic examination, or if you have a new sudden onset of severe headache, the emergency room provider will do a emergent non-contrast head CT. Non-contrast head CTs are good for showing blood on the brain and are better than MRIs for that, and they are quicker to obtain. So if you go to the emergency room with a severe headache and they do a head CT instead of an MRI, that's the thought process behind that. All right, so we've excluded the secondary headache. Now we need to identify the primary headache syndrome. And so I'm going to talk about migraine with aura because this is by far the most common primary headache syndrome. And the without is the more common than the with, but we'll talk about both as we go. So the migraine without aura, this is what we use for when we do studies or research criteria. It looks kind of like a Chinese restaurant menu. Pick one from this menu, from this column, and one from this column. But what I think is a more helpful way to diagnose migraine headache is something called the ID migraine screener. So the 3 strongest predictors of having a migraine headache are: is there nausea, is there disability, meaning you can't work or continue with your activities, and is there photophobia or light sensitivity. So if you have two of these three things, 93% chance you have a migraine, and if you have 3 out of 3, 98% chance that you're having a migraine. And then another type of migraine is a migraine with aura. Now, migraine with aura is most commonly visual, like you see in the bottom picture, where there's a blurry spot or dark spot. It might be surrounded with rainbow lights or flashing lights. Usually that starts small and grows bigger as the headache progresses. You can have some visual hallucinations, some temporary vision loss as a visual aura. You can also have a sensory aura, which is most commonly numbness, especially in an arm or face. Then there can also be weakness as an aura, so a motor aura or a hemiplegic migraine. You could have difficulty with speech. You can have vestibular systems, meaning you get vertigo during a migraine. So these are all auras. They precede the headache and spread over about 5 minutes. The typical aura lasts for about 5 or 60 minutes, usually unilateral, and are followed by a headache within 1 hour. So once we've diagnosed migraine, and we've diagnosed migraine with or without aura, the next thing we need to do is give it a number based on the number of headache days. So the cutoff is 15 headache days a month. If you have more, then you are diagnosed with chronic migraine. If you have less, then you're diagnosed with episodic migraine. In addition to the migraine auras, we can have associated symptoms that go along with the migraine. One of the most common is neck pain and stiffness. So about 70% of people with migraine get stiffness in their neck before the headache. You can have neck pain and occipital neuralgia. This can be without any kind of disc issue, neck issue, nothing organic happening outside of the brain itself. It's that the sensory system for the trigeminal nerve, which does the sensation for the face, is millimeters away from the area that does the sensation for the upper neck. And so if you look here, the purple is the trigeminal nerve branches, and the blue is the area of the high spinal cord that's coded for the sensory areas of those back of the head. Another thing is neck pain and stiffness is very common as a prodrome, and we're going to talk as a prodrome in a second. But I wanted to also talk about that this neck pain can happen with the headache, before the headache, and even a long time before the headache as in a prodrome. Other features that can go along with migraine are nasal congestion, pain centered around the sinuses, and watery eyes. And in this way, patients can get misdiagnosed with sinus headaches because of that overlap. So in this sort of Venn diagram, you can see on the left the migraine, and on the right the sinus, and in the middle the purple that has the overlap. So when you have nasal congestion, pain centered around the sinuses, and watery eyes, you would want to ask, is there nausea, vomiting, light and sound sensitivity? If so, that's likely a migraine. If you're getting nasal discharge and a fever, ear and tooth pain, maybe that's a sinus infection instead. So why is this so confusing? During a migraine headache, there is swelling of the mucous migraines, mucus covering of the nasal cavities. So on the right, you can see what if you took a scope and you put it up your nose, you would see the septum, which is the midline of the nose, and then you would see the turbinate. The turbinate's job is to warm, filter, and humidify the air. And if you look at the cartoon on top, you can see this little outpouching here that is the turbinate. So if you stuck your finger up your nose, that would be what you would touch, is the inferior turbinate. So in a migraine, on the left of the cartoon, you can see they're trying to show the mucosal membrane swelling. That swelling can actually trap the mucus in the sinus areas. So we can have sinus pressure and something that feels very much like a sinus headache because of the swelling of these mucus linings of the nose during a migraine. Next, I'm going to talk about the pathophysiology of migraine, and this gets a little complicated, but hang in there. I think you'll get it. It helps explain how some of these therapies, newer therapies, work and why we have to be very careful if you have fibromuscular dysplasia in what we prescribe. So the brain, through some type of trigger, activates the hypothalamus, which then sends a pain signal or a activation signal that starts the cascade of migraine headache. It goes down to the brainstem. You can see in these light blue arrows, it travels out through a nerve, the nerve called the C fiber that's in green. And then once it gets to the end of that nerve, it goes to the insert over on the left. And you see that green nerve that's carrying those impulses of pain, that when it hits the end of that, electricity hits the end of that nerve, it releases these neurochemicals. And the neurochemicals we're highlighting here are CGRP, and those are the little red dots that you can see. Those little CGRP neurochemicals are housed in these packets called vesicles. The vesicle then, when the electricity from the nerve hits it, fuses with the membrane and dumps its contents outside of the nerve. So you see those little pods with the CGRP neurochemicals in there, fusing with the membrane and dumping their little red CGRP molecules into the space between the two nerves and the blood vessel. And we call that a synapse, that little gap or area between the nerves. So once those little red molecules, the CGRP, is released from the green C fiber nerve, it has a couple options. It can go and it can bind to an artery, and in the bottom left of the insert you see MMA, standing for middle meningeal artery. Once that binds to that receptor, it causes the middle meningeal artery to dilate, to get bigger. And as that does get bigger, a delta fiber, the yellow nerve on the bottom, picks up that stretch. And once that is picked up, it sends a signal of pain back to the brain that now the pain recognizes you're having pain and you're having a headache. So the CGRP can cause difficulty by causing vasodilation. Here we go, vasodilation. And it can also cause difficulty by sending a pain signal back to the brain. So the one way to treat the migraine is to block this CGRP chemical. Before we had the ability to do that, we would use medications called triptans. And what triptans would do would be bind to that green nerve and make it so the CGRP could not be released into the synapse. Another thing that triptans would do is they would bind to that middle meningeal artery that is dilated with the migraine, and they would cause that artery to constrict. So it would actually get smaller than when it started out with. One of the dangers of doing this in people who have fragile blood vessels or blood vessels with aneurysms or other things is that vasoconstriction can cause disruption to the blood vessel wall in patients who have fragile blood vessel walls. Also, if there is a dissection or if there is hardening of the arteries, narrowing that blood vessel can be quite dangerous as it's constricting blood flow. And so one of our strategies for treating migraines in people who have fibromuscular dysplasia is to avoid the triptans so that we can avoid that vasoconstriction. CGRP will cause the vasodilation. So one thing we could do is get rid of the CGRP, and that would make it so you cannot make that artery dilate or get big and send the pain signals. So some of our newer medications either attack the CGRP when it's in the synapse, or they block the CGRP from getting to that receptor. And that way they can stop the migraine headache before it gets started. Botox interrupts the ability of that pod or vesicle of CGRP to fuse with the membrane of the nerve and get released into the synapse. So this, while very complicated and intense, is also super helpful for understanding why you are prescribed the medication that you are. So this is a timeline of the migraine attack, and I promised that we would get back to prodrome when I talked about the neck pain. So a prodrome can happen a few hours to a few days before a migraine headache. And while neck pain is one of the symptoms of prodromes, other things include irritability, depression, yawning, increased need to urinate, certain food cravings like chocolate, fatigue. And what we found is patients who do have a prodrome are 70% accurate on predicting that they're going to get a migraine when they have a prodrome. And we are actually asking people to treat earlier at the prodrome now so that we can avoid the actual pain that comes. If we miss the prodrome and you do have an aura, treating at the aura is also very successful in avoiding pain. If we are unable to avoid the treat at the prodrome or aura and treat at the first sign of the headache, it is still often successful, but not as successful if we could get it in the pre-phase. So the headache lasts from 4 to 72 hours, and then after the headache, we can have a postdrome, which is sort of this fatigue or hangover feeling that we get. So once we have identified our primary headache, we've diagnosed episodic or chronic, the next thing we want to do is identify comorbidities, so disease processes that occur with the migraine, and exacerbating factors or triggers, things that maybe we can avoid in order to have less migraine headaches. And here's a very long list of common migraine triggers. I highlighted a few that are more common, like stress or a letdown after a lot of stress, weather changes, female hormone levels, and then on the left are some foods like MSG, alcohol, smoked or cured meats. Red wine seems to be a big factor. Any kind of nitrates also seem to be a big trigger. So many people who have migraines suffer from other disease states, meaning that like if you have a sleep disorder, it's more likely that you're going to also have migraine. If you have migraine, it's more likely that you're also going to have a sleep disorder. And this is something called comorbidity. So one of the reasons I'm here today is that fibromuscular dysplasia is found to be a comorbidity with migraine headache. And while more people with fibromuscular dysplasia get migraines, just because you have migraines doesn't necessarily mean you're going to have fibromuscular dysplasia. So it's a one-way comorbidity, but it has special considerations that you and I need to talk about today. And most of those considerations have to do with the migraine therapy. So when you have a headache, what are you going to take? So while there are many over-the-counter preparations, many people with fibromuscular dysplasia are not supposed to use anti-inflammatories, and I leave that up to your vascular medicine doctor. Many of the vascular medicines doctor are not very fond of having caffeine because caffeine is a vasoconstrictor. And so most of the over-the-counter preparations, while they can be helpful for some people, usually include some type of caffeine and some kind of non-steroidal anti-inflammatory. So when you see your doctor, they're going to do a diagnosis. They should educate you with their diagnosis. They may ask you to keep a migraine diary so that you can identify and avoid triggers. There's many apps now that can act as a migraine diary that are fantastic. And then we'll figure out an individual management plan for you. So we want to find a medication that terminates the attack quickly, decreases the risks for the next attack. We want the medicine we prescribe to allow you to return to work and daily activities as quickly as possible. So our treatment goals are going to be treat it fast, treat it so it doesn't come back, and get you back to work or whatever it is that you want to do. So some things that we think about: how fast does it need to work? Is there associated nausea, vomiting? So can you keep a pill down? Does the headache happen? Do you wake up with a headache so you don't get to treat at the prodrome or the aura? Does it last a long time? But also very important is tolerability and avoiding medications that are contraindicated, specifically in vascular disease. And so I put up this common chart of migraines to treat medications. And as you can see, where we start with the anti-inflammatory, if contraindicated, go to acetaminophen. Those are things that are usually not available to you as a fibromuscular dysplasia patient. Also, the triptans we want to avoid because of the vasoconstriction. So our first response then as an acute treatment should be treating with a G-PANT, and some brand names for G-PANTs that we use for acute therapy are Nurtec and Ubrelvy, or Ditan, and the Ditan also does not cause vasoconstriction. And the brand name for that, currently we just have one that is called Rayvow. We also know that people have reduced GI motility during a migraine headache. And so we will often prescribe a non-oral medication, something that is not a pill. We have one G-PANT nasal spray called Zavspret, and that is safe for cardiovascular. If you are allowed to use anti-inflammatories, we have one nasal spray which is called Sprix. Prevention therapy. So when do we initiate prevention therapy? Prevention therapy is a medication that you would take every day to keep the headache away. And those would be started if you had frequent headaches. I usually try and shoot for 4 to 6 headache days a month that are easily treated with migraine medicine. So we want to have a prevention if there's a tendency to overuse over-the-counter medications, or if these migraines are severe and disabling. Because we have such a limit on the medications we can use to treat migraines with fibromuscular dysplasia, I usually more aggressively prevent so that we are more successful at treating acutely, so that since we have a limited range of medications we can use responsibly. So again, I'm going to go back to this medications to treat migraine because up until last year, on the right, we have our preventative treatments listed. We had to try and fail to cheaper medications prior to getting some of the newer CGRP therapies. As you can see, some of these are beta blockers and calcium channel blockers that do affect the caliber of blood vessels, and so we always would think those through pretty carefully. However, recent guidelines have come out in March of 2024 that recommend that calcitonin gene-related peptide targeting medications should be used first line, and especially in patients who have cardiovascular comorbidities. And so this just, was a position statement that we put out that said there's no reason to try these medications that were not developed specifically for migraine when we have medications that have been specifically developed to treat migraine and treat it safely and treat it without side effects that have been quite intolerable and have made it difficult to continue with the preventative therapy. We found that about 60% of people who are on preventative therapy ended up stopping because of side effects. Some of the procedures that we have to help with migraine management. So once we found your preventative medication, we will start that. But every now and then we get to a headache that between your preventative medication and acute medication that we need something more to treat with. And these are some of the interventions that we can do to try and help to break headaches. All of that except for Botox. Botox is actually an injection that helps prevent migraine headaches. There's also options that are neuromodulation. So if you decide that medications are not for you, or you're having trouble tolerating them, or they're not working, we have a few devices that we can try. While there are 4, well, the sphenopalatine ganglion stimulation, that device is not made anymore. So we have the vagal nerve stimulator, we have a transcutaneous supraorbital nerve stimulator. There are implanted supraorbital nerve stimulators and now occipital nerve stimulators. There's deep brain stimulators, and there's transmagnetic stimulation. There's a trial currently going on with supraorbital occipital nerve stimulator implantation for migraine headaches. However, all the others have had FDA approval. And can be quite effective for either treatment or prevention. So the most common neuromodulators now are the Cephally, the Nerivio device, and the GammaCore Sapphire. These summarize it a little. Currently, unless you are a veteran, it is actually hard to get insurance to cover these, so the cost point does seem to be a bit difficult. Many of my patients will use the Cephally device. Even though it's $500, it has a 6-week return policy, and then you're done. There's no continuing cost except for electrodes, which is about $25 a year. A lower entry price point is the Nerivio device, which currently they will give you 12 uses for $49. And then after you use those 12, it goes up to $99. And that is a device that's worn on the arm and has been quite effective. GammaCore has been probably the most successful of these neuromodulations, but at a price point that most people find is inaccessible, which is about $575 a month. So what are you going to expect at your appointment? We're going to expect that your healthcare provider gives you a correct diagnosis, that they educate you about your diagnosis and treatment and discuss why the medications that they're going to use are safe for you and why they are not going to use ones that are not safe for you, such as the triptans, and then develop an individualized management plan considering non-drug treatments if possible, maybe adjusting medication depending on how you're reacting to it, how effective it is, what the side effect profile is, and then considering preventative therapy. Also very important that I don't need to talk to you guys about is advocating for your own disease process. So the most important thing that I feel like many providers leave out is empowering patients to be actively involved in their own management. So much like your advocacy group here today, we also have many migraine advocacy groups. The American Migraine Foundation has videos that you can watch. There is a Shades for Migraine Day on June 21st, which is the longest day of the year, and helps raise awareness for people who have migraine that are light sensitive and sometimes need to wear sunglasses indoors. Here in Cleveland, we have a Miles for Migraine walk or rest event. This was last year's, forgive me for not changing, it's July 18th this year. But this is a national organization that regardless of where you are, if you're in the Americas, you could probably find an event near you. Also, to keep up on trials that you probably also know about from your amazing advocacy in fibromuscular dysplasia is this clinicaltrials.gov site. So if you feel like you want to try something new or help other people find new therapies, this would be a good one. And so a quick plug for Shades for Migraine on June 25th. If you go onto their website and you can download some things like this and help raise awareness for migraine headache. Thank you very much for having me speak today, and it was a pleasure working with you. Thank you.